the panelists for the Telehealth Roundtable, and if you could please come onto the stage. I'd also like to invite the co-chairs, Laurie and Anita, if you can also come onto the stage. We'll have a few questions that we will ask thought leaders in the field, and I think it'll spur a lot of questions for us on our flight back on lessons learned from other programs across the country. And as Tudor and Dr. Garcia-Rivera mentioned, there's a lot of ways in which we can share best practices and learn from that and improve stroke networks across the country. At the end of the day, what we want is the right infrastructure to be able to support innovative technologies to come into benefit patients. I'd like to introduce our panel. First, I'd like to introduce my co-chairs. Anita Guthman is a nurse by training, and she works in Dallas-Fort Worth with HCA, and she's done a lot of work on telemedicine. She sits on the National Task Force for HCA on telemedicine, looking at vendors, physician support, as well as integrated solutions. Laurie Massaro is a co-chair for this workshop, and she's been the driver behind some of the success at UPMC Stroke Center, as Dr. Jovin has mentioned. So Laurie, thanks for taking the time. Dr. Jovin needs a little introduction, but he's been a champion not just of endovascular therapies and novel, innovative ways of removing clots, but is also a very committed stroke neurologist and is committed to developing telestroke networks. Dr. Niels Mueller-Kronast is an interventional neurologist with Tenet South Florida Health System and has really put together a wonderful program of telestroke with community hospitals. And so I'd love to hear some lessons learned from him. We've got Dr. Paul Hansen from the Texas Stroke Institute in North Texas in Dallas-Fort Worth. And Dr. Hansen is a stroke and interventional neurologist who has a passion for stroke care and is involved with the telestroke program that sees close to 2,500 telestroke consults a year. And we've got Dr. Ricardo Garcia-Rivera, who gave a talk earlier. He's with NeuroCall and is with a third-party physician specialty organization that supports telestroke. So thank you all to the panelists for being here. It's certainly a wide array of thought leaders that we have. I was just going to ask a few questions and be able to help us think out aloud on these interesting networks. Dr. Jovin, if I could start with you, since you just gave your talk, and I'm going to go in random order over here so I confuse the panelists. But Dr. Jovin, if you can talk a little bit, I think it was really intriguing, one of the slides that you had showed about a CAT scan in an ambulance, as well as mobile platforms to be able to connect with paramedics who are trying to triage the patient to the right facility. Can you talk a little bit to us about the future of telemedicine, especially with telestroke, and your thoughts on telemedicine in the ambulance, telemedicine in the neuro-ICU, and telestroke, not just in the acute phase, but also in satellite health clinics? If you can just talk a little bit on the future of telestroke and your thoughts.
Yeah, thank you. So the acute care component is going to be driven by data. Okay, so I'm making an assumption here that we will have data to support endovascular therapy. We know there's already been one trial. There's a few others on the way. Assuming the data goes into the direction that we all want it to go, or think it's going to go, I think it's going to endovascular stroke therapy will move from optional, which is what it currently is, to mandatory. Okay, and there will be a need to change the stroke models of care, and stroke models of care will probably hopefully will be organized just like trauma centers by levels of services, and are going to be all about time. So the next step will be, even though we've made great strides on reducing the times, the ridiculous times that we saw in in IMS and MR rescue, and it has nothing to do with IMS-3. It has to do with the way stroke was practiced in this country at that time. It was a wake-up call, IMS-3, and it showed us how slow we were. We made great progress with the next generation of trials in terms of reducing times, but that's not enough. So the question will be, how do we reduce times to the absolute minimum, just like the cardiologists have their door-to-balloon time. Door-to-balloon means door-to-recanalization, because when they put a balloon up, the vessel opens up. So they have 60 minutes, usually. So we're going to need to, the next battle, the next step will be, how do we get to these kind of times? And one such approach is to triage these patients, to get them to the angio suite in the most efficient way possible. And that, to me, will be before the patient arrives to the hospital. We have all the gizmos now, we have all the technology, and we don't even imagine what the technology is going to look like 10 years ago, because 10 years ago from, in the past, in 2004, we couldn't imagine what we have available now. And so I think the sky is the limit in terms of our ability to examine and triage these patients in the field, including CT scanners in ambulances and things like that. I don't know that CT scanners in ambulances are going to be something that are going to be standard in every ambulance or in every stroke system of care. It has remains to be seen whether these scanners, these ambulances can cover a wide population. But certainly technology, I have no doubts, will help us triage these patients and bring them to the interventional suite in the fastest possible amount of time. So that's to the acute pre-hospital component. I think, again, we need to look at the data on how patients do once they're treated at local centers versus more comprehensive, more sophisticated centers. I suspect we may realize that giving TPA is not the whole part of the story, that there's a post-care component that we have to be aware of and raise the overall level of care with stroke. And I think telemedicine will have a role in that. I don't see why, for instance, telemedicine could not be used to see the patient in follow-up or provide consultations in hospital. The problem with that is that it's not being paid right now. But once the reimbursement issues are worked out, I can again see the sky's the limit kind of situation for these inpatient consultations. And then outpatient stroke telemedicine is I think of enormous potential worldwide, not only within the US, but I see us having sort of huge practices that are worldwide, that everybody in the world can eventually connect to a stroke neurologist or an interventionist and discuss their problem. Of course, regulatory issues are in the way, but I think the market, the people's will, if you want, are gonna solve all these problems.
Great. Thanks for that insight into the future. There seems to be a lot of exciting advances. I have a question for you, Dr. Niels Mueller-Kronast. Having built a telestroke network with community hospitals outside a university academic setup, can you talk to us about the challenges you faced, and did you need administrative support, like a telehealth administrator or somebody in your health system that supports telemedicine to be able to bring all these community hospitals together? And if you could talk to us a little bit on that and give a perspective on community hospitals and the telestroke network, that would be great for the audience.
I think I can speak to that because I've been through 2 iterations of telehealth system. My first telehealth system was rural in Indiana, and I would have loved to have a lot more buy-in from administration. I never had a telehealth administrator. I think we would have been much more successful. It took us 3 years to grow to 20 hospitals there. I think buy-in and support from the administration is crucial. You can make a pretty good business case, especially in rural environments, because you can bring a lot more patients to your hub hospital, and you can overall raise the standard in the community. I think the challenge that I'm in right now is very different, because in an urban environment, it's not really the patient's geography that determines, it's really having the physician resources that don't come to the hospital and providing consistent care in a timely manner. We struggle right now transferring patients from one hospital that's 5 miles away to another, and that takes 2 hours. So their telehealth is also a solution. Again, I've had to work many different channels. I've had to sell buying the telehealth infrastructure through other channels, like through video conferencing budgets, so that I could have the technology available, because there is a hard business case to be made, you know, because there's really no dedicated reimbursement associated to it. I think what we're forgetting, though, is that it's not really how expensive your toy is. It's not really how, you know, do you use a self-driving robot or this or that. In the end, it is, do you get the information you need to make the treatment decision? And if you have a good ER physician with whom you have a good relationship, and he describes a clear-cut MCS syndrome, and you can see the scan, sometimes that's enough, and you don't necessarily need to waste another 5 minutes to boot your computer, look at that through a video camera. So it has to be individualized. It's just another extension. It's a tool like a reflex hammer or whatever else may be. What I think we need to focus on is what happens in terms of your physician staff. What do you get out of it? If you contract it out and you don't have good follow-up after the stroke treatment decision is made, you leave a patient in an environment where there's no stroke champion, where there's no follow-up care, where they're exposed to higher complication rates. And I think that's where I'm struggling right now, is just having the physician component where people are motivated, interested in stroke care, and are ready to deliver that care. That is really the challenge that I'm doing right now. We've had a very successful pilot, but we've actually scaled it back because I can't get the funding models attached to it right now, where we pay people to the extent that they want to do this call. It has to be something that's reimbursed through the organization. That's where you have to plead with your administrators. But I think it's something that will not go away. I think where I want to caution is the enthusiasm about the stroke mobiles and the CT scanners. When you live in an urban environment like this, I don't think physicians are really that helpful seeing another weak patient in an ambulance through a blurry picture that's held by a paramedic of an iPhone. You can, with good training, get that same information from a paramedic and make a field-based triage decision. I don't think we're going to have a scanner on every ambulance. I don't think it's realistic. It's just going to blow every budget. So the question is more, can we get good validated scores that in an urban environment, very different from, let's say, Pennsylvania when you travel, transporting 200 miles, but in an urban environment, when the next stroke center is less than 15 minutes away, can you get to an agreement that we transfer these patients field-based, based on the score, directly to the right center? I think that's a much more successful, much more straightforward, and much more cost-efficient strategy. So I don't really think stroke telehealth in the ambulance will be as, it's my personal opinion, will be as big of a presence as, you know, Tudor may think, but, you know, it remains to be seen. In the end, it comes down to funding, and I'm sure we're going to see a couple of CT-based ambulances just because it's a cool toy to have.
That's a great perspective, and there may be differences in urban metroplex and rural markets, and lessons for us to learn, especially in centers that have large geographies that need to be covered, like our speaker from Colorado and the case study from Maryland, patients being transferred to Pennsylvania across state lines. So I think that field is probably still evolving. I want to ask a quick question on rural market to Dr. Hansen, who comes from another large geography in Texas. If you can talk to us a little bit, Dr. Hansen, on how many hospitals your telestroke network covers, and also in terms of has your telestroke network made an impact on treatment rates that you've seen?
Sure. So I cover a large swath of North Texas with the Texas Stroke Institute. Over the last 5 years, the program has really been built from scratch. One of the biggest helps that we've had is a dedicated transfer center, where it's a one line in, where they can get a hold of a group of stroke neurologists, neurointerventionists, neurocritical care docs that are on call. We're covering, we get calls regularly from about 120 different hospitals in the North Texas region. A lot of these are rural hospitals that don't have neurology, they don't have neurosurgery, they don't have a lot of help. It may just be a couple bed ER. We're crossing state lines. We get patients from Oklahoma. We've had at least one patient from New Mexico, and I believe even from western Louisiana. So getting all of those rural markets in line really came about by having a simple one-number contact that really gets them brought into our service. We started out, I think 5 years ago with maybe about 900 calls over the course of a year, and I think we're on pace for 2,400 calls this year, or possibly a few more. And it's a mix of telephone call, a mix of camera call, and with those two technologies, we're able to really reach out and increase our treatment rates. We're getting 75% or more TPA on all the eligible patients. So that's something that really probably 10 years ago we couldn't do. TPA rates just weren't that high. So we've had pretty good success there.
Do you have access to imaging on all these patients?
We don't have access to all of them. We have access to all of them that are in our, within the HCA network. We get access to all of those. The rest of them, what we're relying on is an ER physician that is able to give us a coherent story, like what you're talking about. We've been pretty confident and pretty successful getting TPA, sometimes sight unseen of the scan, or we're told over the phone, CT scan has been read, there is no bleed. We get a really good story from that ER doc, and we feel confident getting them in, because we just can't have cameras in 120 different places.
Well, because that kind of gives you the opportunity to actually verify, related to what Niels mentioned, whether this video connection is really necessary, or whether imaging or phone, or are your outcomes better or different or worse in patients in whom you do only telephone encounter versus the ones with video connection.
And that's data that we're still collecting. What I can tell you is that our TPA rate has gone up, our bleed rate has gone down, and the number of patients that we're seeing has gone through the roof.
Regardless of video connection or not.
Regardless.
Yeah. Well, I think that, the future will tell us who is right. I think that technology will be so easy. A phone call will be so easy. A video connection will be as easy as a phone call. Yeah. That all these issues that Niels brought up now, that are real issues today, are not going to be a problem in the future.
I agree.
All this video stuff.
I think when it gets that easy, when the phone call and the camera console, is one step.
Why not do a camera console?
Right. Yeah. Then I think then it'll be a no-brainer.
But right now, I agree, there's still technical issues, delays, and so on and so forth. But I think all the technology will make all this obsolete. But it's hard to tell what's going to come. You know how they say, it's difficult to make predictions, especially when it's about the future.
I think the one thing that is sort of being left out of the discussion here, probably Anita and I can both vouch for it, is part of the whole implementation process with a hub and spoke model, or when you're partnering to provide these types of services, it's so much more than the camera. It is about the education, the tools, the resources, the relationships that you establish with the practitioners at the spoke site. So let me just give you an example. In Pittsburgh, it takes an average of 3 to 4 months to get a hospital ready to go online. And that, some of it has to do with credentialing, but we also review all of their protocols, we standardize their protocols, we do education for the nurses, we do education for the physicians, we run mock stroke alerts for both the ED and the inpatient units to have them gain a comfort level with what's going to happen whenever they access this telestroke resource. So there's, and then there's the follow-up piece. So we also review with each of our hospitals our symptomatic hemorrhages, our 90-day modified Rankine. So we're looking at post-treatment, what happens to that patient. And if there are breakdowns in communication or process or deviations from the expected protocol, we try to circle back and have a conversation with those hospitals about what happened and how we can do better the next time. And then the last piece of that is ongoing education. So figuring out how to keep in touch with those hospitals on at least a monthly basis. One of the things we've done is we've started monthly education sessions via telemedicine. So every month we have a different speaker that's broadcast that they log into that it provides some educational value for the physicians, for the nurses, for the team who's assessing and caring for those patients on the distal end. And a couple times a year we just do case review. So we'll just pull some complex cases and look at those case reviews as part of the education that we provide to them on a monthly basis.
Thank you, Lori. I think that's a great point. Just in the interest of time, I'm going to ask that if we have any questions at the end of the session, we can again ask about telemedicine. But if it's okay, we will try to stick to time and move on to our next roundtable. But this has been a great discussion, wonderful talks from Dr. Garcia-Rivera as well as Dr. Jovin on a couple of models on a third-party physician specialty organization versus a hub-and-spoke model where the physicians are within the comprehensive stroke center, and some challenges that are there with credentialing, with rollout across these hospitals, maintaining them, different technologies, different applications of the ER, ambulance. So it's a very intriguing and exciting field, and it needs to be mirrored with the growth that's happening on the innovative technology side. And I think if both of those are partnered along with the stroke center growth, the infrastructure will be laid out for time-sensitive diseases. So I want to thank each one of our panelists. I wish we had more time to talk, but I just want to mention to the audience that our panelists are around, and please, if there are any offline questions. Thank you again.